Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gaulin.
Hey everyone, welcome to this episode of the Gastro Girl podcast. Today we're diving into a topic that's becoming increasingly important for parents. They're wondering what the connection is between eczema, asthma, and eosinophilic esophagitis, or EoE. And today, if you're wondering how these conditions might be related, you're in the right place because we have back again our fabulous and one of our most favorite guest experts, Dr. Sophia Patel from the Cleveland Clinic. And if you remember from previous episodes, Dr. Patel is a leading expert in pediatric gastroenterology, specializing in eosinophilic disorders and their impact on children's health. She is also the co-director of the Pediatric Eosinophilic Gastrointestinal Disorders Clinic at the Cleveland Clinic, where she offers specialized care for children in managing these complex conditions. Thank you, and so nice to see you, Dr. Patel.
Thank you so much for having me again, Jackie. It's always so fun to join and talk about EoE.
Yes, and for those, we've done several episodes, and you've starred in all of them related to pediatric pretty much. But for those who may be finding us for the first time, can we just give a little brief overview of what exactly eosinophilic esophagitis is, otherwise known as EoE?
Absolutely.
And how does it differ from more common digestive conditions that parents might have heard of?
So EoE is a relatively newer diagnosis in terms of medical terms. It's only been around or identified as a separate disease since the early 1990s. And so what we notice with EoE primarily is older patients will present with symptoms of dysphagia, which is difficulty swallowing, food sticking in their throat, especially when they're eating, as well as having difficulty with their appetite. They're slow eaters. They take a long time to eat. Younger patients often present with more nonspecific symptoms. So those are things like abdominal pain, nausea, vomiting. They're picky eaters, which is really hard to discern from just their age group. And a lot of times they can't really tell you if their stomach is hurting or if something else is causing them pain. So the younger patients are a little bit harder to figure out. And it's a little bit different than acid reflux, which sometimes we see in kids who also present with abdominal pain, but typically it's not something that is persistent or it gets better with time, comes and goes. Whereas EoE, the symptoms are a little bit more continuous, and typically patients have symptoms on a more regular basis.
Thank you for that. And now as we set up for the conversation, many parents may be familiar with eczema and asthma, but can you briefly explain these conditions and their common symptoms in children?
Absolutely. So asthma is a condition that affects many children, and oftentimes it's known as its one primary issue is wheezing. And many kids are genetically more susceptible to asthma. Oftentimes they will get an illness or a cold and it triggers wheezing symptoms, but it essentially is very similar to eosinophilic esophagitis in that those allergy cells and those pathways trigger the airway to actually become hyperreactive, and it forms in different ways, can cause you to have wheezing, coughing, shortness of breath, and similar to what we see patients with. And it can happen with exercise, it can happen without exercise, it can happen in different seasons, it can happen, just on its own. And many patients have to have long-term treatment for asthma. Eczema is something that oftentimes and both of these are things that you'll see diagnosed by your pediatrician, and it's very classic symptoms. Similarly, so eczema just like asthma, can present very early on in as young as toddlers, infants, and the patients usually present with kind of these patchy areas of skin irritation or dryness. And those are not something that often goes away, sometimes worse during different seasons, not always caused by different food exposures, but can be associated with different allergenic food exposures. And eczema itself is, something that can happen alone or with asthma, or, in addition to other atopic diseases.
No, thank you for that. Now, the $1 million question is, what's the potential relationship between all three of those, EoE, eczema, and asthma? Do they share a common underlying cause or pathophysiology? Like, what's the
Yeah.
connection?
Absolutely. So, what we know about EoE and these other diseases are they are all under the umbrella of atopic diseases. So, an atopic disease is thought to originate from different immune pathways. And in EoE, eczema, and asthma, it's actually a very similar immune pathway. We know that Th2 cells, which are one of the major causes of eosinophilic esophagitis, produces certain cytokines, which are different parts of the immune pathway that have central roles in EoE. And those cytokines include cytokines IL-4, 5, and 13. And they cause, a pathway of causing those eosinophils to get into the esophagus. And similarly, in patients who have Th2 mediated diseases, which also involve asthma and eczema, that's the reason why that whole disease umbrella can also include EoE. So it's all kind of starting from the T cell, the type 2 inflammation, and then the Th2 cells that produce the cytokines that can cause all the similar atopic conditions.
So interesting. So, are children with eczema or asthma at higher risk of developing EoE? And if so, why is this?
So it absolutely is. And I don't know if we have exactly all the reasons why. There's a lot of very complex genetic and familial and pathogenic processes that probably lead to an increase in the patients with atopy and eczema having a higher risk of EoE. But having those diseases overall increases your risk of having other atopic diseases. So similar to having eczema or asthma individually can increase your risk of having either of those diseases. You can also have an increased risk of seasonal allergic rhinitis, nasal polyps, and there are some other allergic diseases that can be also associated with that same kind of the atopic umbrella. So essentially, we have patients who have EoE, and a very large proportion of them, especially the ones who have more significant symptoms of EoE, present earlier, or they actually have more dysphagia symptoms, and oftentimes they're more symptomatic, often have also other atopic diseases too. And it's very common for patients with EoE to have other atopic diseases as well.
Yeah, and as we were talking before we started recording this episode, and I was telling you about that experience with a mutual friend's son, and he was, he had asthma and he was having signs of failure to thrive, trouble eating, and all the classic signs you're going to go into later.
Mhm.
But it led me to be curious about this connection and, to lead to the next question, which does having one of these condition cause the other? So for instance, in that young child, because he had asthma, did it cause, and he was ultimately, as we talked about, diagnosed with EoE like months later. But did that asthma cause his EoE? Is there a relationship, or is it more of a shared immune system or allergic response issue? How would you explain that?
Yeah, that's a really great question. I would say that it's not a causative of another disease. Having that kind of what we call an asthma and allergy patients, we call it the atopic march. And that is when very early on you have these triggers and whatever it may be. Maybe it's from your family history. Maybe it's from seasonal allergies. Maybe it's from, something that triggered it early on. But we know that those diseases are all associated with each other, but they're not causative. So that's something to kind of keep separated. In itself, EoE they have very similar pathogenesis of these other chronic disorders. And again, it kind of goes back to that Th2, the type 2 inflammatory spectrum. And that could include the dermatitis, allergic rhinitis, and asthma, and also with nasal polyps as well. And those patients, because they have one, they just have an increased risk of having another. So if you do have someone that has eczema and asthma, and oftentimes my patients, when I get referred, they come from the allergist because they're seeing them for all those other issues, or they have food allergies, or they have different spectrum of those allergic disorders, and that just kind of heightens your risk of developing EoE later on, or having a higher risk of just having EoE as a child and just in general because you have those other diseases.
So this is a great segue to the next question, which is what are the symptoms of EoE that parents should look out for, especially if their child already has a condition like eczema or asthma or both?
Yeah. So a lot of parents will already kind of be hyper aware of different foods that may trigger some of their children's symptoms. And a lot of times, we'll see infants or children and they'll say, they ate this food and then they had issues right away. You could tell they had hives or their face turned red. And then, so these parents are often, maybe not as much as the parents who just have the asthma and the wheezing, but the atopic dermatitis parents can often make a link between they ate this and then these symptoms happened. And so that often is kind of makes them already aware that certain foods can be triggers for eczema, and foods don't cause eczema, but we know that there's probably some link between the top 6 allergenic foods and those things causing more symptoms in patients, especially with EoE. So those patients are the parents are already probably a little bit more aware of like what foods may set off more symptoms. And in those patients, what essentially we see is oftentimes they are having abdominal pain as well. They're having vomiting episodes, and the vomiting is usually not associated with any specific food intake. It can be really from, maybe they just had something out of the ordinary or they just had something they eat all the time. It's not always related to a specific food because there isn't like that immediate reaction that there would be in, if you have a food allergy. In EoE, it's a kind of a progressive disease. So it's kind of chronic exposure to those allergens that causes the symptoms over time. So it's not going to be, you drink milk and then immediately you throw up. That's not often what we see in our EoE patients. A lot of those patients are a little bit more sensitive anyway to certain foods or different triggers, but that's not often what we see first. But abdominal pain, nausea, vomiting, and that's very episodic and recurrent. Trouble with swallowing foods, so especially drier foods like sandwiches, bagels, bread, steak, chicken, that kind of thing. And typically those patients are the ones who are eating a little bit slower. They're taking a long time to finish their foods. The parents notice that maybe their appetite isn't as good as their other siblings. They're like the last person at the table. They're cutting food up into small pieces. They're drinking a lot of water in between bites. Those are typically kind of the signs and symptoms that we're seeing in these patients and things that you want to look out for if you're concerned that your child might have that.
So you may have touched on this a little earlier, but it's so confusing sometimes, like how we can differentiate in parents between a typical food allergy and the symptoms of EoE. Can you expand on that a little more to explain that it's not really a food allergy, but what's happening in the body?
Yeah, absolutely. So food allergies and EoE, we know, are definitely related in some way. Like we talked about, having an atopic disease just puts you at a slightly higher risk of developing EoE more than the general population. And what we know is that with food allergies, they are mediated a little bit separately by an IgE mediated pathway, which means that it's a kind of a different allergen pathway than the Th2 system. And what happens when you have a food allergy is you eat or drink something and you have an immediate reaction to it. You have swelling, hives. You can get, anaphylaxis type symptoms where your throat closes and you have difficulty breathing. In EoE, the type of foods that we know that trigger it are milk-containing foods, dairy products, sometimes eggs, sometimes wheat, sometimes soy in older patients. But those foods, what ends up happening is instead of it being an immediate reaction, they have the exposure to those food proteins over time. And what's kind of led up to this is there's some barrier dysfunction in the esophagus. So the esophagus normally should be nice and everything's closed up. Nothing's allowed to, no antigens are allowed to get in there and open things up. And we know that there's probably some unique microbiome in the esophagus that we don't know as much about. And there's a lot of up and coming studies about that too. But that barrier dysfunction allows those antigens to enter into the esophagus and cause the recruitment of those eosinophils into there. So you're talking, the food is getting in there, it's irritating the tissue, it's sending signals to the very early pathways, those cytokines we talked about, and it's leading to a cascade of these cells, inflammatory cells, different, and there's also probably a genetic predisposition. So it's kind of causing that trigger to cause the eosinophils to get into the esophagus. And then that leads to the typical symptoms that patients experience. And the issue is that, you can eat the food, Probably. And I mean, most people that see us are, they're eating dairy, they're eating all kinds of things all day long, a couple of glasses of milk here, a few slices of pizza, and they're getting that exposure kind of continuously. So I always tell patients that, if you're going to go on a food elimination, it has to be all or nothing, because if you do get even just little bits of it here and there, that is enough to cause the recruitment of those eosinophils and cause the inflammation. It'll probably be better if you're not eating it all the time, but having that continuous exposure is what causes the eosinophils to get into that area.
Oh, that's interesting. But before, the parent, what parents just start eliminating foods from their kids. They don't even know what's going on. So this is a really important time to talk about at what point should parents consider taking their child to see a gastroenterologist if they suspect EoE, or if they notice a pattern of these allergies, asthma or eczema, if they should see those specialists.
Yeah. So a lot of times, what we end up seeing is patients who have just been having kind of like random abdominal pain, vomiting, or maybe their pediatrician saw them already. They put them on Pepcid or an acid medication, and they're just really not noticing much of a difference. Really, like any parent who's concerned about their child's GI symptoms and they feel like they want to get a really deep dive into what's going on should be referred just to GI in general. And then those patients can also come not just from your pediatrician, from family medicine, from maybe your parent themselves have similar symptoms and they're like, oh, my kid might have similar symptoms. And then that patient gets referred. It also comes from pediatric allergy, immunology. I get patients also from our pulmonology colleagues because they have asthma. And then they kind of, I have a couple of people who they're like, okay, well, maybe you should start an acid medication if you feel like you're having some vomiting. But if that's happening, then you should go see GI because that could be, something else related to this. And I also get referrals from dermatology because those are the patients that are seen for eczema, for atopic dermatitis. And then, they may bring up that, hey, I ate some food and it made me feel not great. And, that does prompt a referral too. So it can really come from a variety of different places, including the parent themselves. So,
yeah, no, this is really helpful. And I think, it's fascinating that there's a whole subspecialty within pediatrics, pediatric gastroenterology. And I want to just touch on that now because I don't know, our listeners are very intelligent. They know a lot, and this is not meant to diminish anyone's knowledge, but I just want to just highlight the role of the pediatric gastroenterologist and what you do at the Cleveland Clinic. Could you explain that and its highlight? Because it's scary, right? When you think, oh my God, my kid's going to go to a gastroenterologist and they're going to start getting all these things put down their throat. And
is that going to happen today? Like maybe.
Yeah. So just, put us at ease. And there's a gentleness, right? And then I think gastroenterologists are great anyway, but there's a gentleness to what you do. And it could be scary for a child. So tell us a little bit more about the specialty area that you're in.
And that's a really good point that you bring up. I think, as pediatric, first as a pediatrician, we're always like rule number one as a doctor, a pediatrician is do no harm, right? So I don't normally meet patients for the first time and say, okay, hi, nice to meet you. Here's your scope. I always tell patients that at the end of the visit is I am never trying to actively scope a patient that I meet for the first time. I like to get to know you, like to watch your growth chart for a little bit. If there are very clear signs and symptoms that you have EoE, and that typically happens in older patients, then we have a very long discussion about what the next steps will be. And generally patients don't get scoped, on the very first visit with me. It's not like you're going to go to ENT and then surprise, you're going to get a nasal scope the same day. Although that is a capability we have. And, it is something that, we prep patients for this though. You can't walk in and just get a nasal scope done the first day. So one day maybe, but not right now. What we try to do is start with, getting to know everyone, getting to know your child, really kind of diving into the symptoms. And that's why the first visit sometimes can be quite long. In our combined multidisciplinary EoE clinic, and I always joke with my allergist, Dr. Schroer, who I work with in our clinic, it is a very popular clinic, so it's hard to get into sometimes. But we do spend a very long time with all the patients, and you can expect to be there between 40 to 60 minutes at least. And we also have our dietitian who works with us and helps with dietary elimination. And we have my care coordinator, Adelina, who's wonderful. She's a nurse who works with us very closely and works on getting medications approved, works on talking to patients about their symptoms and trying to figure out, what the next best steps are. And it's just, it's a great clinic to have because you really get to talk for a very long time and, discuss all the concerns, every possible treatment, because there are so many available treatments now that, you can't really cover them in one office visit with one, GI doctor, or even like after a scope. It's really hard to kind of get all of that into one visit. And we try to take our time and spend a lot of time with you. I always tell kids, I don't carry shots around in my pocket, so I'm not going to I'm not going to surprise them with anything. I like to prepare people for what to expect. And like I said, I don't like to meet people for the first time and immediately say, okay, hi, nice to meet you. Here's your scope. And I prefer to kind of get to know them. And even if they get referred for very specific symptoms, it's important for it to be a shared process. It's not something that, I'm going to say you absolutely, this is it. The only thing you can do is XYZ and you have to get this done. And this is when we're going to do it. I think it definitely is more of a back and forth, and it's a discussion more than anything. So,
no, and thank you for bringing in the multidisciplinary approach with the allergist, potential dermatologist, the dietitian, because all of these specialists play an important role on the care team. And if I was a parent, it would put my mind at ease knowing there's multidisciplinary, there's different things going on with my child. And I would feel comfortable knowing that there's this team that can look at the different areas of my child's health and what's going on.
Absolutely. And it's great that I get to work with our allergy colleagues because they also, they can tackle the asthma. They can tackle some of the atopic dermatitis. And we work down the hallway from one of our dermatologists, and I often refer patients to her too, especially for treatment for, topical treatments for eczema. And I think it's really great to work just in an environment that has so many specialists and a team that works together and really works to get your child seen by everyone that they need to be seen by.
Yeah, and this is it brings us to an important part in the discussion is the diagnosis and testing. So what does the diagnostic process look like for EoE in pediatric patients? And what tests should parents be aware of? And on the same time, food triggers identified, how are they identified in children with EoE, eczema, or asthma? And how does that all work together? I know it's a mouthful, but I know it's like, but the way you answer is going to cover all this. That's why I wanted to get the question out.
Absolutely. So the main way that we diagnose EoE is with an endoscopy, which is a scope where we take a camera and look into the esophagus, which is the food pipe, and into the stomach and the small intestine. So for that procedure, that requires sedation or anesthesia for the first time that they have it done. And the procedure is pretty short. It only takes about 7 to 10 minutes, and it is lower risk of the procedures that you've probably heard of before, like tonsillectomy, adenoidectomy. There's a very low risk of bleeding or infection involved. The bigger risk is of poking a hole through the tissue or perforation, which is still happens in like less than 1 in 10,000 patients. And unfortunately, right now, that is really the only best way to diagnose EoE. There's a lot of studies looking into other non-invasive ways to get it diagnosed. And it is really, it's not great that we have to put patients to sleep, especially kids, to get a diagnosis of the EoE. And there's a lot of studies and data going on looking into non-invasive ways to do that. And that can vary from doing like a breath test, or there's an esophageal string test that is in development and actually in other centers. But that's a little bit difficult because it's a capsule you have to swallow, and getting a 3-year-old to do that is probably going to be, a little bit more difficult, time consuming. We also offer at the Cleveland Clinic a transnasal endoscopy, which is a scope that can be done while you're awake instead of asleep. The youngest patient we've done that on is a 4-year-old. And I can tell you he did not love it, but it was doable, and he did not need anesthesia to get put to sleep. We usually do a lidocaine spray in their nose and a lidocaine spray in the mouth, as well as like a swallowable lidocaine jelly. And that will allow us to do a scope while the patient does not have to get put to sleep. And that scope takes about 5 to 7 minutes to complete. It's very short. And we've done, over 75 this year. Since
Oh,
beginning
wow.
the program about 2 years ago, we've done over, 150 of these. And like the parents love it.
I
The
was going to say,
patients
that was my next
Patients are
question.
about 50-50. So they get it done. Then, we ask them right after, we're like, would you do it again? And right after, they're usually like, I don't think so. Normally what happens is after, several weeks, or if they reintroduce the food that we ask them to remove, we ask them, I always ask again, do you want to do the transnasal endoscopy, or do you want to get put to sleep? And a lot of them come back for second and third times. So I would say probably about 60% of them come back to have it redone. And then that other, 40% will opt to do the sleep scope. So.
And what are you looking at for parents that are wondering, like, what are they looking at? Are they
Yeah,
taking
so
biopsies?
exactly. So what we're looking at are three different things. In the sleep scope, we can also do an endoflip, which is a type of measuring device that can look to see how flexible and pliable the esophagus is, which can tell us a little bit more about whether or not there's any deeper fibrosis in the tissue, which is kind of the biggest concern we have with EoE. Is over time, those eosinophils, the longer they stay there, the higher risk the patient has of developing scar tissue or fibrosis, and we're trying to prevent that with the treatment. So what we're looking at when we go in with the scope is we're visually looking with our eyes initially to see if there's any changes of EoE, which can be swelling in the esophagus. You can see linear lines, these kind of train track lines going down. You can see rings in the esophagus, which are not supposed to be there. And you also see these little white patches, which are actually just little collections of eosinophils. And then while we're in there, we do biopsies in at least 2 to 3 parts of the esophagus, and we send them to our pathologists who look at it under the microscope. And that's the true diagnosis of EoE is under the microscope. They count how many eosinophils there are in each field of the microscope, and anything over 15 is abnormal.
Oh, wow. So once you diagnose a patient with EoE, what are the current treatment options? And I know you did a great podcast episode, so you don't need to go into too much depth here, but just to kind of give parents a sense of what their options are.
There's many different options. So I think we're really lucky to be in a very up and coming time for EoE too. So the primary options that have been around for many years are food elimination, which we know that there are certain foods that trigger EoE. And in almost 60% of kids, dairy is one of the biggest triggers. Dairy, which can include milk products, butter, cheese, yogurt, all that stuff. And so one of the treatment options we offer is a dairy elimination, which is can be a little bit difficult to follow, especially if there's a patient that already has, eliminating other foods. So if they're allergic to eggs or they're allergic to nuts, it's hard to add in another food sometimes. And also the older patients, they don't love to do food elimination as their first go ahead, but it's always something that we talk about, and how we support them in the clinic is by having them meet with our dietitian and kind of talk with them about what it would look like to be off of all dairy products. And it's not always dairy. So the top 4 foods that trigger EoE are milk, wheat, eggs, and soy. And in some patients, shellfish, fish, eggs, nuts are other triggers as well. But typically, we like to start with one food because we know the efficacy of using a 1 food elimination versus 2 to 4 foods is about the same in kids. And other treatments include topical corticosteroids, which are similar to what you would use in asthma, but instead of inhaling them, it's like you would use the inhaler and you spray it into your mouth and then you swallow it. And that's a type of a steroid that's inside of the inhaler. There's another version of that comes as a little nebulizer capsule that you usually put in the nebulizer machine, but you actually open it up and you put it into a medicine cup with some honey, maple syrup, Splenda, or applesauce. And we have patients swallow that twice a day. And what that does is it kind of goes in and it kind of coats the throat, similar to like if you would have like a cream or something for like a eczema rash. It's kind of like covering or coating it and decreasing the inflammation that way. Other treatments can include proton pump inhibitor, which help improve the barrier function that we talked about earlier in the esophagus. And in about 30% of patients, proton pump inhibitors, which would be like Nexium, Prilosec, Prevacid, higher doses of those can treat EoE as well. And then the last kind of category of treatment would be biologic therapies, which are a little bit newer, and they are recently approved by the FDA, but they work very well. And one of those medications is called dupilumab. And that medication is an injectable medicine, which has been approved for asthma for, I think, over 5 to 8 years. And it works in kind of blocking one of the pathways that causes the eosinophils, several of the pathways, actually, IL-4, 5, and 13, I believe, blocking it from reaching the esophagus.
So there are options. Do you have, maybe there's different protocols for the age and what the parents want to do, but is there a typical, what you do with your patients, or it depends? Everyone's unique, right?
Yeah. And really, like every conversation, even in our EoE clinic, we have between 4 to 6 patients scheduled, and we have the same conversation with all of them, but the decision making always kind of branches off at some point, where it's like, some patients are, very concerned about using medication long term. Some patients are very, they don't think that doing a dietary elimination would fit their lifestyle. So it varies between patients. So, but we offer all the options, not saying that you have to do one or the other. But that's the important part about treating EoE, is like that shared decision making that really kind of helps people really stick with the diagnosis and management plan. Because if you don't think you're going to be able to do it, then, that's something that we're realistic about, right? I mean, I would love to be like, okay, everyone should just start with just removing all these foods from their diet. But realistically, these are kids. They go to school, they share food with their friends. They're at someone else's house on a Friday night. Their mom orders pizza. Like, what are they going to do? It's hard, to pick something that fits a certain lifestyle. And that's why we always tell patients too, you can always change therapy. But the big thing is, after you choose a therapy, the only way that you can really tell if it's worked or not is by repeating the biopsy and the endoscopy to check to see if it is actually healed or not.
Yeah. And this is so important is, because and you've said this over and over again, is that EoE is a progressive disease. And if it's left untreated, there are complications. And we're not trying to scare people, but we do want to educate so that you have the information that you need, patients and parents who are listening, that you can make an educated decision in partnership with your provider. So I want to ask Dr. Patel, please explain some of the long-term complications, even in pediatric patients, of untreated EoE, and how can parents prevent them?
Absolutely. One of the things that I tell people to make them feel a little bit better is that EoE has not been associated with any cancers, which is great. But it is associated over time with the increased risk of morbidities that include fibrosis of the esophagus. And those fibrosis can lead to having recurrent food impactions, which are when food gets stuck and it actually does not go down. And you've probably all had a pill get stuck somewhere and you're like, oh my gosh, it still feels like it's in there. And you're drinking a bunch of water and it still feels like it's in there. But these patients are not even able to tolerate their oral secretions when the food gets stuck in there. And that is really what we're trying to prevent over time. Because when patients present later on, over many, many years of having more inflammation, that inflammation turns into scar tissue. So the earlier we can catch it, diagnose it, and hopefully treat it consistently, it decreases your risk of developing that scar tissue or the fibrosis. And it stops you from having the increased risk of those food impactions, which leads you to have, emergency procedures in the middle of the night or in the evening, or you would need a dilation, which we don't love to do, but will do if it's necessary. Dilations can be very painful, and they're also associated with high risks of, just risks of perforation, which is like tearing a rent in the esophagus. Those kind of things are what we're trying to prevent over time.
No, this is such great information. And I know we could talk about this all afternoon. You have some great previous episodes that that walk parents through in more detail about EoE, the causes, as well as the treatment options and updates. And we'll put those links in our description. But before we go, what is the most important thing? I have two more questions. What is the most important thing parents should know if their child has any combination of these conditions, EoE, asthma, eczema?
That's a great question. I think, alluding to your point in the beginning is trying not to change too much before you see a gastroenterologist, I think is really important. We have a lot of patients who get referred to us and they've been, on an acid medication for 6 months or 8 months. And, if you are concerned about your child and they're on a medication for a long time and you keep trying to stop it and it still comes back, that should kind of like set off some like little alarm bells. Like, well, why has my kid been on Nexium for 6 months? And every time we stop it, he has pain. That kind of thing to me is concerning because that means that, you shouldn't, as a child, you shouldn't need a medication, right? Ideally, you would like to have a medication that you can use for a temporary period of time and then be able to stop it. For me, that would be like the acid medication. So if you are really, if your child has asthma, eczema, food allergies, and they're having stomach issues, that should kind of, give you a little bit of pause and say, maybe I should see someone and talk about this a little bit more. Because what we see in our clinic is we are talking to patients and they're like, wow, like I never even thought about any of these things because we're asking these very specific random questions about, did you eat a bagel once and what happened when you ate a bagel? And they're like, what? Like, I don't even like bagels. And we're like, well, why don't you like bagels? What's wrong with bagels? And then and usually what happens is the child will tell you, they'll say, well, one time I had it, and it felt real weird going down. And then we're diving into, well, how did it feel? Like, what do you mean? Like, how did it go down? Did you have to drink some water? And then it kind of leads into this path of questioning. And really, like, as a parent, you're not, probably spending a lot of time being like, well, cross-examining your child like under a light or whatever.
Right.
But it's hard because you're not thinking about that, right? Whereas we are like, this is what we see all the time. So it's something that we're always asking about. It's like taking that extra step. But anything that sets off your alarm bells of, well, maybe he shouldn't have been on a PPI for this long. Like, why do we think maybe he's not tolerating milk as much as we thought he did? Or, why does he feel better off of certain foods? Those kind of things should prompt you to consider talking to a specialist for just a little bit longer of a period of time. And that'll also help with, determining whether or not he or she, your child, needs more testing or if they need other specialists involved to help with their care.
No, this is great. And finally, what resources or support groups would you recommend for families navigating EoE, eczema, and asthma?
Yeah, there are actually quite a few. One of the major sites that I like to refer patients to is appfed.org. And appfed is a great organization that has a lot of great patient information. They have a lot of great patient studies. And Seeker is another study site that does enroll patients in clinical trials. At Cleveland Clinic, we also have, our support group, which is part of our EoE clinic. And typically what we do is we haven't yet formed this, but it's something that we're hoping to form in the future with EoE patients. And, having them at least have like an educational type day experience and understand like how it feels to have EoE and have a friend with EoE. And a lot of times that's how patients get referred is they're like, oh, well, I knew so-and-so and they had EoE and they came and saw you guys. And this sounded like what they had too. And having that support system, I think, is important too.
Yeah, AppFed has great resources. And it's a great support for families and parents and patients. So thank you for mentioning that.
NASPGHAN as well. So NASPGHAN is the Pediatric GI Society, and their website, gikids.org, is a wonderful source of a lot of literature and information. And of course, the best source would be your local gastroenterologist as well.
Thank you. Well, it's always a pleasure to have you on the show. Thank you so much, Dr. Patel, for joining us today and sharing your expertise on this important and very interesting topic. We've learned so much about these connections between EoE, eczema, and asthma, as what parents can do to manage, recognize, and support their children with this. So for our listeners, remember you're not alone on this journey. If you have questions, concerns, or need support, be sure to consult with your healthcare provider and check out the resources like the Gastro Girl podcast and appfed.org, as well as the Cleveland Clinic for more information. And don't forget to subscribe to our podcast, leave a review, and follow us on social media for the latest updates and tips. Thank you for listening, and see you next time.
Thank you.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.